Good morning, everybody. My name is Councillor Jane Davis and I have the honour of chairing the Health and Wellbeing, the Health Select Committee, slip of the tongue. And so I'm very pleased to open this morning's meeting. We will start with apologies and substitutions. Apologies have been received from Councillor Lainey Barker, and Councillor Tamara Ray has kindly stepped in to substitute for Councillor Barker. Thank you. The minutes of the previous meeting, I have asked for a repeated paragraph in the minutes of the last meeting. It's on page 15 of the agenda pack, minute number 44, to be amended. We want to remove the following paragraph. It was a block contract that was fixed for the life of the contract. So for a provider, there was certainty about funding for the life of the contract, and it gave flexibility to be able to plan longer term and to be sustainable. There would be the usual mandated uplifts that are applied so that any NHS uplifts fall through the BCF are applied as those come through and can be included. So following that change, can I ask you if people are happy with the minutes and that we can approve them? All right. So I move we approve the minutes of the meeting held on the 9th of July 2025. I'm looking for a proposer and a seconder. Proposer Chuck Berry, seconder Monica Devron, Councillor Monica Devron. All in favour? Aye. Thank you very much. Are there any declarations of disposable interests or dispensations granted by the Standards Committee? No? Thank you very much. Right, Chairman's announcements. Members will have received an invitation to attend Trowbridge Integrated Care Centre site visit on the 25th of September with the Health and Wellbeing Board members. I would encourage you all to attend if possible. Thank you. Public participation. The committee has received 2 questions from a member of the public, Chris Caswell, which were published as an agenda supplement yesterday. Do I need to read through the whole question?
They are obviously in the supplement. They're obviously on the supplements if the committee want you to read them, or you can just give your verbal response.
Would you like me to? I will read through just for clarity. Chris Caswell asked, I wish to ask about a statement in the section of the previous minutes of the discussion of the handover of the Integrated Community-Based Care contract to HCRG. Those minutes include an unchallenged assertion that it is not a privatisation of the NHS. An extraordinary assertion given that HCRG is a large private company recently taken over by a private equity company 2020 Capital. Private equity companies, by their own admission, aim to grow the value of the business, typically sell on after 5 to 7 years. This 7-year HCRG contract is worth up to 1.3 billion, according to published analyses. HCRG turnover for the year ended 31st of March 2024 was 265.8 million, with profit after tax of 8.9 million. All revenue came from NHS contracts. Taking all this and more into account, will you agree to at least delete the assertion that it is not privatisation from the minutes, and preferably replace it with a factually correct statement that HCRG is a private equity company making substantial profits from NHS contracts? Now, the response obviously was prepared with reference to Democratic Services, and the verbal response is that minutes record the discussions that take place at the meeting, and the statement highlighted in question was part of the evidence given by a witness in response to questions from the committee. Committees decide whether to approve the minutes of the previous meeting as an accurate record under the relevant item. I was happy with that because it was a comment that was recorded in the minutes and it was said, and I recall it being said. Mr. Caswell has a second question about those minutes. The same July minutes make a brief reference to the upcoming absorption of Baines, Swindon and Wiltshire ICB, which has already absorbed the Wiltshire Clinical Commissioning Group into a huge cluster ICB stretching across Dorset and Somerset, as well as the existing BSW area. At the same time, it is reported that the Labour Secretary of State has cut the existing BSWICB budget in half. The ICB, of course, provide a vital channel for NHS resources and decisions that deeply affect the citizens of Wiltshire. not least the GP practices in the primary care sector. This being so, it is remarkable that yet another ICB reorganisation and resource reduction is not included in this committee's forward work programme. Will you agree to at least review that work programme with a view to either including ICB developments or reporting why it is not sufficiently important to be there? The response is that the committee is scrutinising the transformation of health services in Wiltshire and the impact of national decisions on the delivery of local health care services will be considered as part of the committee's ongoing scrutiny, so that the impact of cluster changes will appear in our scrutiny and will be considered. And I'm certainly happy to commit to a resolution by the council that the national picture is considered as part of our ongoing work scrutinising local health select committees. Do I have any comments on that? No? Thank you very much. I've also been asked to do take an urgent item under questions, and I'm going to invite Councillor Dr. Monica Devlin to speak on her question.
Thank you. Thank you. Thank you, Madam Chairman. I just wanted to bring an urgent item to the attention of the committee as well as to be escalated to the Health and Wellbeing Board. For the past number of years, I've consistently escalated the urgent need for Amesbury to have an additional pharmacy. When the ICB requested evidence, I went directly to the people I serve. I collected specific, detailed feedback from my residents and submitted it in good faith. Later last year, a third applicant sought to open a pharmacy in Amesbury. Despite the clear demand, the application was rejected on the grounds of the PNA being published in 2022. When the consultation for this new PNA was launched earlier this year, I again encouraged my residents to complete the survey so that very real challenges could be heard. The long waiting times, the struggle to access medicines, and the inadequacy of existing provision. Yet, despite their input, I'm disappointed to see that the draft PNA does not reflect the urgent need for an additional pharmacy in Amesbury. Madam Chairman, the difficulties my residents face have been met with a deaf ear. My representations raised time and again has been disregarded. Amesbury is one of the fastest growing towns in Wiltshire. It is unacceptable that my residents are forced to queue for long periods, often in inclement weather conditions, simply to access essential pharmacy services. If the draft PNA only describes existing provision without recognising these daily struggles and the pressures of the population growing, it risks locking Amesbury into under-provision for the years to come. I therefore ask that my comments today be formally noted and passed on to the Health and Wellbeing Board and the group overseeing the PNA. I urge them to revisit this decision and ensure the framework allows for an additional pharmacy in Amesbury. My residents deserve timely, accessible and adequate pharmacy provision, and I will continue to stand on their behalf until this is delivered. Let it be clear, Amesbury is growing and the people will not be ignored. The Health and Wellbeing Board must act swiftly to provide the additional pharmacy needs that Amesbury needs. Thank you.
Thank you very much for that. I'm certainly happy to note your comments. As you're aware, it's a responsibility of the Health and Wellbeing Board to agree the pharmacy needs assessment. But I think that you speak very well as an advocate on behalf of your residents, and I applaud you for that. So thank you. Do we have any comments or questions on responses to that? I see Councillor Claire Cape, who's the Cabinet Member for the NHS, is here, so she would like to speak.
Yeah, just very briefly, thank you for that, Monica. I'd be very happy if you would copy me into your letter to the Health and Wellbeing Board. I'll take that forward. Thanks.
Thank you. Right, our first agenda item on health topics is the integrated community-based care contract update. The committee received a report on the integrated community-based care contract in July, and we requested further updates at this meeting and in November to include examples of the impact of transformation on services. And members also asked for details of the development of the neurodiversity pathway. I thank you for the update report, which starts on page 29 of the agenda pack. I think Caroline Holmes is here to speak to this. Can I ask that the committee focus on the specific lines of inquiry that the committee has asked about? So it's focusing on the impact of transformation on services and specifically on the neurodiversity pathway. I'm asking this because we need to be realistic about the amount of information that we can usefully absorb. Our focus as a committee is very much on the services as experienced by residents. And there's a lot of information in the report which deals more with management and personnel issues. So I am going to ask in future when we have papers come to meetings that they have an executive summary that responds very specifically to the questions the committee are asking, because otherwise we can all suffer from an overload of information. So thank you. And when you speak, can you speak to the two questions specifically? Thank you.
Thank you. Thank you, everybody. I'm Caroline Holmes. I'm the Interim Executive Director of Place for Wiltshire. Just to, and apologies if there was a level of detail in the report that you weren't requesting. I think we had a number of areas required for information, and so we were asked to select from that. So apologies, we will make sure that we return to those other areas next time as well. So the report in front of you just gives a brief update for you all on the first 5 months of operation of this new contract. We also have information for you on the transformation plans and particularly the autism, ADHD and neurodevelopment pathway. We also have included for you a summary of the outcomes framework, which is how we assess performance and the impact of the contract and how that's developing. But what I would suggest is, from your original request, that we take the paper as read and we just focus on those two elements, particularly around transformation and autism, ADHD and neurodevelopment pathway. So I just also wanted to just introduce Vals Grace, who's the Regional Director for HCRG, and also Laura Ambler, who is the Executive Director of Place for Baines in the ICB, and also our Portfolio Lead for Learning Disabilities, Autism and Neurodiversity, amongst other things as well. But she'll also be here to help support answering any questions that you have. So I'll just pass over to Val to take us through transformation and autism, ADHD and neurodivergent pathway.
Apologies. Let me kick off first of all with the transformation. So I think when we came back in June, July, we talked about the safe mobilisation, and at that stage we were just starting to plan for our transformation programme. We are now, and we've set up our transformation programme and governance, both internally and externally reporting to our commissioners, including our ICB and our Wiltshire Council colleagues. And we're using a methodology that for the first last 3 months has very much been around discovering and understanding the services as they stand at the moment. And as part of that, a huge programme of engagement with our communities, with our service users, with our stakeholders, to understand what they understand about community services, what they need, what they see as the improvements for access, for responsiveness, for how they want to access services within the community. And we're just about to pull that together to go into our design and deliver phase, which is really putting those into action. And as we go through that phase, we will continue to work with our communities and work with our service users and stakeholders to get that right. By the end of the financial year, end of March, we will have delivered some really key programmes which will include a digital front door for those that are digitally enabled, but equally, really importantly, a single point of access and care coordination centre with people to talk to, as well as a neighbourhood health model. And there's more and more guidance coming down, as many of you will probably recognise, on neighbourhoods, both from a neighbourhood health perspective, but also from a local authority, community and police perspective as well. So a lot of work that we're doing to understand what that neighbourhood health looks like with our partners. I'll just stop there on the transformation, if I may.
Thank you very much for that. I'm sure councillors will have questions. One thing that really interests me is co-production and what good co-production really looks like. And I wondered if you could give us an example of a kind of person-centred transformation thing as it. And I recognise that it's still in progress, the transformation, but how that would work, a person-centred example.
So it's really building on what is already there and then identifying where perhaps we haven't got good engagement. So a number of the areas, like if we look at our children and young people, we're very much engaging with Wiltshire Parent and Carer Council, and we can bring out an example as part of the LD pathway as well, if that would be helpful. Also, our youth, if I give you an example around the youth event that we have currently been holding, is around that single point of access and our digital front door. And some of the terminology that we had presented, which we thought was plain English, not NHS language, actually they gave us some really helpful feedback about what terminology means for them, because we are very much encouraging self-referral, both from a parent perspective but also from a young person perspective. So it gave us some really great feedback that we are working with our supplier on to make sure that we put into that digital front door. They also confirm with us how important it is for things like QR codes. And for some of our hard to reach youngsters, they, for example, said actually that would be really useful to have your QR code in places like police stations that perhaps we hadn't recognised as an area that might be useful. We put it in our family hubs, we put it in our GP practices. So just widening that space for us to actually access, for them to access the services. So just one of those examples. From a neighbourhood health perspective, in Wiltshire, we already have the Wiltshire Collaborative programme, which has been a programme that's been in place for the last couple of years, very much working with our community and voluntary sector partners in each of the areas. So we've been we have a partnership and engagement team led by our head of partnership engagement, Phil Waters. Phil Waters comes very much from a voluntary sector background, not an NHS background. He's been working with the various Wiltshire collaboratives to build on that work already that's there.
Thank you. I think that's very interesting. I was also wondering about the digital door and how people will know it's there, and perhaps for older people. I don't like to stereotype older people. My mother's 86 and she's a whiz on IT, but not everybody is how people will know about digital door. And it came to mind again because you were mentioning QR codes, and I'm always a bit wary about QR codes. So.
Me also, I don't think anybody would call me a digital whiz either. So, but during the procurement process and engagement that took place as part of that, it was really, really clear that actually people wanted digital access. That certainly some of the work that we've done, and I think it's probably particularly visible across Wiltshire, is because Wiltshire residents' pathways with PCNs connect very much to 3 different acute trusts. We need to really get into that connectivity and functionality with our acute trusts and make the journey as easy as possible. So What we're doing at the moment is not looking at the digital answer, but looking at what is it that service users need to have in front of them to access services. So they're talking about responsive, easy access, that they can connect through GP practices when they go to an acute trust in community buildings. And we're taking that feedback to then give to our digital transformation team to go, this is what people want, this is what our colleagues are saying also is needed, this is what our stakeholders are needing, what is the solution? One of the things, and it's very much part of the NHS 10-year plan as well, is how do we increase the use of NHS apps, because many people already have that on their phones. So how do we increase and connect through the NHS app as well? Now that will be part of the work that we do, but we're also expecting some more national direction and guidance on that as well. And QR code is just, particularly if you talk to young people, that's a really easy access for many younger people to access services. So at the moment, it's collecting the ask, what are people wanting? We are really clear that we want to put in place self-referral to all of our community services. We already have that in place in a number of our services that we had previously provided, and we can certainly talk about that with the ND pathway for our children and young people. But actually people want to go direct to services. We do not want our GP and primary care colleagues to be gatekeeping our services. They've got far more demands in their space. So again, connecting with people to understand the digital access, but then also understanding for those that are not digitally enabled, actually they want to talk to people. They want what we're calling care navigators to help them to understand how they navigate the system.
Councillor Williams.
Thank you. I just build on this as an elderly person myself. I don't mind admitting that these days, though I may not look it. QR codes we are familiar with, because to access Netflix, BBC iPlayer, or anything else with the streaming services, the first thing that comes up is a QR code on the screen, which you then go onto your laptop and you sort it all out. So it's not that big an issue. One of my things is that, and we've discussed this before, I'm Ludgershall based and all that, and I know you are familiar with the town, but how are you going to access, you talk about you go to the surgeries and put the codes up, but how are you going to access the guy on the street, if you like, and who may not be aware, or mostly is not aware of the services and what this represents and all that. So
the communication, and I apologise, Councillor Davies, because I didn't actually answer that question. So I think one of the really important and aspirational opportunities with this contract is that we are a lead provider, but it has been recognised that community services are huge, and we cannot deliver this alone. So some of the really, really important work that we're doing is engaging with our colleagues and stakeholders in the local authority, in primary care, in our acute trusts. And when we launch our new systems, this has to be some really consistent communication across our local authority and our health providers generally. So we will communicate in the broadest sense. But the other thing that our service users are saying is that they don't feel they get consistent advice across health services. So when they've got a particular issue, health need, they don't necessarily know where to access. Is it a pharmacy? Is it a GP? Is it an ED department? So one of the pieces of work that we will be doing together is that really consistent communication with advice on where do you go for different health needs. And I'm recognising your point around border issues and recognising the housing that we know is going on, but it happens to be in Hampshire. We will have to really work with our border counties as well to make sure that people are really clear about where they go to which service. And there is complexity around that, as we've discussed before.
if I may just to say though, but what I would urge you to do is to use us as the local councils on the ground, use the area board system. I speak on behalf of all the councils and area boards as well, but I'm sure we would welcome that because we can get that information out there. And especially most of us are on social media, Facebook. So if you prepare something on that, I certainly would share it in our local community as well, just to raise the profile of what you're doing. It may raise lots of questions of what's going on as well, and some comments, but at least you're going to get that message out there.
And thank you, that's really, really helpful. And I think anywhere that we can communicate, I think is going to be really important when we launch those key enablers. I think when we met informally, I think that suggestion to come to area boards or area health and wellbeing boards, we will go anywhere to engage and communicate. So please invite us to things. Thank you.
And I think finally, just to say, keep the language simple. Yeah. It's layman's language, sorry, not the language, well, not health language.
Yes, my ears pricked up at that point about when you did some customer testing on language, that it can be an obstacle rather than what you think you're saying. So I'm really pleased to hear this and would really welcome engagement at the area board level. Councillor Ed Rimmer has a question.
Thank you very much. Yeah, I think it all sounds very promising. But the thing that I'm most interested in with all these things is outcome and how we measure it. And the thing I found very interesting really was item 27, when it was talking about contributing outcome is to ensure that people only need to tell their story once, which I think is something that will resonate with people who've used healthcare services like this. What I'm interested in is how that is measured specifically, if there's a way we can measure that, whether we're sort of auditing that and auditing call transfers and to what extent these things actually happen. And the bigger point, which goes slightly beyond that, is to what extent data on that and anything else can be measurable on a Wiltshire specific level, so that we don't lose local data to, in the kind of, in the bigger picture when we're looking at the three areas together, that we don't lose focus on what's happening for our area as well.
Yeah, thank you very much for that. And it's really helpful, I think, isn't it, to kind of pull out some of those things that people have told us are really important to them. So only telling your story once has been a recurrent theme over a number of years for people, and how we get that right will be really critical. Part of that is about records and shared records, and professionals working together and having access to those records. So that's part of that measure. But as you'll see in the paper, the outcomes framework itself also has some developmental areas as well, which are linked to transformation. So some of the things we will work through as we go forward will be things like patient measures as well, so patient experience measures, and that will absolutely need to include their experience of care and how often they tell their story. So some of the measures and the outcomes that you can see in the paper, because they're linked to transformation that will happen within the first sort of 1 to 3 years, some of those outcomes will be worked through as we go. Some of them are there already, as you can see, with measures, and some are developmental ones to be worked through.
So just to go on, so we have an awful lot of data and activity in health service. We love collecting data, and our systems are set up to report on data. So this is a journey to move to outcomes. It's really, really important that we get to the so what, and we look at the longer journey for our patients and service users. So I think there's lots of ways we can put that in place. I think going back to tell your story once, I think there's all sorts of things from audits, but I think the most powerful thing is listening to service users and looking at case studies and looking, for example, when we get complaints and concerns as well as compliments, as to actually what actually caused some of those issues. And we've been doing a lot of learning, coming back in a minute to the ND pathway, we've been doing a lot of listening and learning around parent and children's experience of that ND diagnostic pathway and how we can improve it. I think you also asked about the Wiltshire focus. So we are really clear that this is a BSW harmonised contract, but that it's really, really important to focus on locality and place, because populations are very, very different. Swindon is very different than Wiltshire and is very different from Bain. So you can just see that from the demographics and the ethnicity and the deprivation. But equally, I think it's also important going forward that we break it right the way down into neighbourhoods and communities as well. So we recognise the different population health needs within different communities. And I think you're all here representing the different communities. You know the different health needs. And we need to be able to bring that back in evidence to you as well.
Thank you. Do you have a supplement?
I'm just going to come back just very quickly and say that, yeah, it's definitely very welcome, especially the tell your story once thing, because it's just just a perception thing that it often feels like with healthcare things that the right hand isn't always talking to the left. So anything that can improve that is definitely a positive. And it's encouraging what you just said about the data, because I think this can be extremely positive, but it's just that reassurance that Wiltshire's data isn't sort of diluted and that the average across the whole area doesn't make it look like things have improved in Wiltshire when they actually are part of a bigger thing. But I welcome what you just said. Thank you.
Do I have any more questions from the committee? Sam?
Just I'm going back to the framework, the outcomes framework. So yeah, I absolutely agree that we should look to this rather than the process, the results. Some of the current areas do seem a little bit vague to me. For example, optimize impact of enablers. I mean, that's very management-esque. And yeah, going back to Jane's point and Chris, you know, really the more specific areas that we can identify as this is what we want to see, I think would be helpful, because I think, you know, for us looking at this as lay people, we will struggle to understand exactly what that means and how that translates to a better service for patients. I do understand that a lot of these are long-term things, but we still, I still think they have to be quite measurable. And again, like improve access and experience, great, but how are we actually measuring that?
So, what you see in your document is what went into the procurement. So it's very, very high level, and you're asking exactly the right questions. And to be honest, as a provider, we're asking those questions, working with our ICB colleagues, but also asking ourselves the questions about what does that actually mean. So in our transformation programme, we have a project stream that is exactly about outcomes, and what our partnership and engagement and our clinical teams are doing is they're taking the questions of outcomes right out to service users, as well as right to our clinical colleagues as well. So when we look at a clinical care pathway, for example, and I think I've probably talked about foot health here before, I can't remember what I've talked about, but foot health. So when we talk about moving away from a service, I need to go and see a podiatrist, what we want to move to is how do I improve the health of my feet, whether that's as a young person because I need to be wearing the right shoes, or whether it's I'm a diabetic, so therefore I need to look after my feet. So we're trying to look at a care pathway approach, and then we're trying to ask both the clinicians and the service users, so what do we measure that says you've got a good outcome? So what do you measure in the prevention space? And then what do you measure in the diabetic clinical care pathway space? So it is complex, but that's how we're trying to get to that methodology to make sense, or make it more sensible to the meeting those service user needs.
Caroline Holmes would like to.
And I mean, it's such a good point, isn't it, when you look back at it and think, well, actually, in isolation, what does that really mean? And it comes back to the point we've just made around, you know, technical speak and usual acronyms that we can be a bit lazy about sometimes. So I think we need to just reflect on how we've described that overarching outcome, which is what it is. But largely what it means is optimizing things like digital, for example, the way we use our estates, and how efficient and productive those services are, and the assets are really. So that's what the enabling element means. And so some of the things that we would want to see in terms of outcomes are things like improved estate utilisation, for example, which means, are we making the most of all the buildings that we have? Are we using them? Are they busy? Are they occupied? Those sorts of things. So which in turn means that we're being as efficient as we can be with those estates and what's available to us, and that we're making sure that we're using that in the right way for patients and service users as well. So making sure the estate is in the right place for the population as well going forward. But that's really helpful, thank you, and we'll take that on board.
Do I have any more questions? No, I mean, I think that this conversation has really helped clarify things, and I think there's a difference between an expert who's enthusiastic and really embedded in their field, writing a report that that when it comes to a committee of lay people, we need something that gives it colour and texture that we understand. I mean, just one thing moving forward, because you're coming back in November again to talk about transformation and outcomes, and we may well invite you again before the end of the year. My ears pricked up about care coordinators, because I think that could be transformative for people's experience. And I just wondered when they might be in place, and that might be a good example of an easy to understand for lay people example of what the difference is.
Care navigators or care coordinators, so very similar function, will be in place as part of the care coordination single point of access by the end of the financial year. But we already have examples of that. It sounds like what might be helpful is to bring along some real life service user stories as well that might actually not always be. I think what might be helpful is the ones that don't go right as well as the ones that go right, isn't it? So we can really give you the evidence of where we haven't got it right and what we're going to do about it. Yeah.
Yes, I think anonymised case studies would be really helpful, because they are very accessible for us. Thank you very much. Diane has a question.
Sorry, just a very quick one. Could you've just mentioned both care navigators and care coordinators. Could you very briefly explain how you see the difference?
The reason I've called them care navigators is because in Wiltshire, some of the primary care networks have care coordinators, and we need to be clear that we're not duplicating and that we've actually got real clarity of role. What I see as a care navigator is someone who is literally able to talk to an individual and help them to navigate the health system, whether it's our community services or whether it's appropriate to signpost them to an early help or a waiting well offer as well. So they can give that initial guidance, because we always have to understand that for some service users, they will be waiting on a waiting list, for example. So it's helping them to help themselves, but really focusing on what is it that is the health need that's bothering you that we need to address first.
Could you confirm or deny that care coordinators will remain in place as opposed to your care navigators?
Are you specifically talking about some of the care coordinators that are sitting within the primary care networks?
Yes.
Yeah, so they are differently funded through the primary care networks. So they do not belong to us. But what we need to make sure is that we're not duplicating, and we're working with our primary care networks to deliver that seamless pathway.
I'm going to think about that, because that's not my understanding, but thank you.
Yeah, I know. Yeah, if you want to email your particular question, because there are some complexities with some of the PCNs. So yeah.
Okay, yes, we don't want to be too specific, but I think an overview of that in November would be helpful. Councillor Hagar. You look so enthusiastic.
I was. You saw that I wanted to. Yeah, I was just interested because I kind of like just thinking about the old care management role. The care management role was about access and gatekeeping, funding and services, whereas the care navigator role is much more about advising, signposting, having a knowledge of the kind of like the supply side, as it were, and saying, well, these are your options. Is that right?
Yes, yes, so we see that role, it's in development, we're in discussion as, certainly not gatekeeping. I think that's
Yeah.
a better word that we want to use at all. It is about listening to someone, understanding their health need, understanding what it is that the individual is most concerned about,
Yeah.
and then making sure that they're on the right pathway. We want to get away from a kind of service condition. So we are, and I'm a nurse by background, and we are notoriously bad at going into a patient and thinking we understand what their health need is. So, you know, we need to give up smoking, for example. Yeah, that might be what I, as a nurse, think might help that person best. But actually, what we know is that that person is smoking because they're under stress, or they're in poverty, or actually their back's hurting and they can't sleep. So what we want our care navigators to do is really listen to people to understand what is the core health need that they want to tackle first, which might or might not be managed within the community health service, but it might be something that actually is impacting on their health that we may not be coping with, either within communities, voluntary sector, statutory agency, etc. Because we're not going to be able to tackle smoking if they're not sleeping, or they've got backache, or they've got house. So it's that.
So it's like an informal assessment of the whole of the needs of the person.
Yeah.
And then how advising that person on how to access support for the whole of their needs.
Yeah. And
So it does
obviously,
replicate care
that's
management in that
probably
sense.
once helping our wider professionals to understand what is actually causing that individual the most concern.
Yeah.
It's trying to get into a more holistic prevention approach, which is where the NHS 10-year plan is trying to get to as well.
Yeah, and people are entitled to make bad decisions, aren't they, with the smoking?
Exactly.
Yeah.
Exactly. Sorry, I think
Okay, thank you.
I think we shouldn't underestimate as well the work that we need to do with our practitioners, because they've been trained to deliver a sometimes medical model. So there's a huge amount of work that we need to do with our professionals as well to change this thinking into a prevention model as well, and a holistic public health model.
Okay, thank you.
Thank you. Are there any more questions on the transformation piece, or shall we move on to neurodivergence? Yep. I believe Lucy Barker is going to speak to us about this.
It's Laura Ambler, Chair. Sorry,
I
no,
do
it's okay.
apologise. I
Lucy-
was just looking at
No,
the
you're
note.
right. Lucy,
Laura Ambler.
Yeah, Lucy has written the paper and is our director. Lucy works in my team and has provided the information for you. So as we've heard, I'll assume the report as read, but maybe just to give you a few highlights. I think it's fair to say we've been working with colleagues in HCRG and indeed across the system for a number of years now, really, to transform provision for children and young people with neurodivergent ADHD and autism traits. When we embarked on the community commissioning that we were looking at, we had the benefit of that joint working, and we had the benefit that we had done some of that co-design that we've been talking about. So what matters to people, telling their story once. So in the autism and ADHD and ND space, we have things like health passports, for example. We have things like My Life Plan, My Housing Plan. So really understanding that person-centred, holistic approach. And I think we recognise that there was a need to improve some of the transitions between children and young people and adulthood. And certainly there was also a need to consider what we might do around some of the waiting times, particularly for those adults with ADHD. I think it's fair to say that's a national issue, so it's not unique, certainly to BSW and not unique here in Wiltshire. But we know that we wanted to take a step back and look at that and think about that in terms of the end-to-end pathway that we were commissioning. So I'm pleased to say that obviously we have gone live on the new community contract, and the efforts of all of that work and the feeding in of the lived voice, we have already had quite positive feedback, particularly around the referrals, as Val was describing earlier. So I think probably that's the main things. You'll see in the report the types of things that we were making clear to people, and we've just touched on it a moment ago around waiting lists, is how we help people to wait well. So part of that is making sure that people are informed and understand the choices that they have available to them. So we took a decision as strategic commissioners to write to everybody that was on the existing waiting list before we transferred that across, just to make sure that everybody understood their current status, where they were, and to ask them what matters to them. You know, were they aware of what they were waiting for, and what might they hope happens next, and to provide some options. So those options are set out under paragraph 24 in your report. So things like the continuation of the NHS right to choose pathway. I'm sure panel members would have heard that there's a requirement that we have a right to choose statement on our website, and we make people aware that they are able to access care from right to choose providers. The waiting well provision that Val has spoken about, what advice and support might be useful for people whilst they might be waiting for a diagnosis, and actually, do they realise that they don't need a diagnosis for things like reasonable adjustments either at the workplace or in college? And then for our schools in particular, I'm really pleased to say that we are now in year 2 of delivering a very successful programme around partnerships for inclusion of neurodiversity in schools. So that's part of that prevention piece, supporting our schools and helping them with the tools and strategies that help support, in particular in that instance, our young people. So that's just a flavour, I think, to bring to life what was in the report, but I'm very happy to answer any questions that you may have.
Councillor Chris Williams.
Thank you. I actually had to Google what this meant. I don't know if other people do, because it's just not terms that I grew up with, to be quite honest. It's all brand new to me, so I'm on a big learning curve myself. And one of the things I worry about is that the more we use this language, and you know, to who goes out to the school and discusses with school, because let's be honest, well, I say we never thought we had these issues or whatever. Probably it was just children were naughty or whatever. You got the cane in those days, back in the 50s and 60s, if you misbehaved. Now you sort of sit down and say, what's wrong with you mentally or whatever that may be causing these issues. Am I correct in thinking that? And if so, who's asking the questions? Is it your team that's going to the schools, or are now teachers more trained to recognise it and do this work as well? Sorry, I'm being very simplistic with it here, but it's
So I
something
think,
I'm having to learn.
yeah, I think I understand the spirit of the question. I think there's a question, isn't there, around is there more prevalence of autism and ADHD and neurodiversity, or is it just that we know more about it now? So I think that's the sort of spirit of your question. So I think what we're saying is it's a bit of both, maybe, and in any event, what we're trying to do is meet the needs that are presenting. So the issue is, I mean, as you describe, you know, not focusing on the behavioural aspects, but trying to understand what's the underlying need, what's the need that's not being met, and how do we address that. So that means taking a trauma-informed approach. That means working directly on what matters to the child and young person, and trying to work in a strengths-based way with the child and young person. So I'm going to hand over to Val to talk about PINS, because you're actually delivering that for us, and it is a wonderful programme that we've had some great feedback on.
And can you start, Val, by telling us what PINS stands for?
So it's about promoting inclusivity in schools. So yes, so just going back to the challenge around neurodiversity, which is the current terminology for a range of conditions from ADHD through to autism. So, and we, even across the age range, our adult services tend to talk about autism and ADHD, and our younger people coming through talk about neurodiversity. And if anybody's looking at our website, and I recognise this because I happen to be talking to one of our MPs in Chippenham, Sarah, and recognise that we've also muddled the terminology on our website. So it's really difficult to, because we're using different terminology for the age range. So we're tackling that one. But I think the medics would say that prevalence has not increased, but our awareness and understanding of children's needs within school have. And so you're absolutely right. A lot of children were labelled as naughty, where probably they were neurodiverse and their needs were not being met within the school environment. this demand for a diagnostic pathway is increased nationally as well as locally. So we're no different here than we are across the national picture. And what we want to, and working with our local authority colleagues and our schools, and again in adult services as well, is trying to move people away from a diagnosis gives me an access to services, because that's a medical model. What we want to work with schools, work with our parents and our communities with is actually, what are your needs? What makes you feel you need to access a diagnostic pathway? And for some children, young people and adults, it's really important that they have a diagnosis because it does give access to things like medication, for example, which for some people can make a real difference if they're ADHD. But not every ADHD individual requires medication or wants medication either. So the way we're, for young people particularly, that we're working really, really closely with schools. And one of the projects that we're delivering is that promoting inclusivity. So we're working with schools, with our team of neurodiverse specialists, therapists, etc., to help schools to understand what's in their power to change, either through teaching differently, around some of the interventions, or by changing the environment in which they're teaching. So PINS 1, which was our first project, we rolled out that support to 40 schools across BSW, and we're now just delivering it to a further 40 schools, and it just started this September for that second project. And it's been really well received.
Yes.
Yeah, because I'm sure this just doesn't start when a child goes to school, but preschool, and therefore I'm looking at what I used to know as the Sure Start centres and that, when the mums and babies went along. So is there some form of programme there for that as well? Because I can't see, perhaps I'm wrong though, you know, everything's fine at home and then all of a sudden the child goes to school and within a couple of years has decided it's got issues there because of the way they're performing in school.
So yes, we're also working really, really closely with family hubs. And in Wiltshire, we also have the public health nursing contract, which is a local authority contract. Our public health nurses, health visitors, as you may know them, are co-delivering in the family hubs and working really closely with our early years setting, again, to identify those needs-led children that might need support, getting them ready for school, getting them successfully into our schools. So we have a all age pathway.
And maybe educating the parents.
Yes,
You know, there's a lot, until you get over this one generation to another generation to another one, you've got to, the parents have got to be able to understand and teach their children.
You're absolutely right. Although there is no gene that has been identified for neurodiversity, we often recognise that when we're working with the parents of children who are not neurodiverse, they have neurodiverse traits as well. So it's helping them to understand and communicate as well.
Thank you very much for providing clarity in that. I was just going to say we must be wary of straying too far into Children's Select territory.
I was just going to add that's one of the benefits of it being an integrated community-based contract, and that we think family first. So you'll see in the language when we write, we talk about the individual and their parent and their carers, so that we think about the whole family. But noting that we won't stray further. Thank you, Chair.
Thank you. Councillor Ed Rimmer, you have a question.
Yeah, just very quickly in response to what you were saying.
Sorry, that was Alan Hagar. Yes, sorry. Ed had his hand up at the same time.
Oh, sorry.
It's all right.
Who
Sorry, you
started?
started.
Right, for clarity, Councillor Alan Hagar.
Thank you. Hagar. Yeah. No, just to say, but what used to happen in the 70s was people were locked up. And I know that because I used to work with them when we would close down all the old hospitals who were full of people who today would be being supported in our schools. And I can also tell you that those kids that were locked up, they hardly had any parental involvement at all. So what a move on we have now, whereby we're talking about how we support people in schools and how we work with parents. It's kind of like a way that we've developed over the last 40, 50 years.
Army, so I joined the army.
Thank you. Councillor Ed Rimmer.
Thank you. I just think it's probably important that we kind of note the fact that this goes a lot bigger than Wiltshire and what we're looking at, because, you know, some of this is, as you said, obviously down to increased numbers of people that, increased prevalence, and some of it's down to increased diagnosis, but there's obviously something going on nationally. You know, we've got the situation. I was just reading a NHS report which said that currently 1 in 5 children aged 8 to 16 have a mental health disorder of some situation, some type currently. So there's obviously something going on which is much bigger than anything we here can really get to the bottom of in those terms. So I guess it's not really a question. I was just kind of trying to say that the stuff that we're talking about here is quite big picture things that we probably can't really affect much on this sort of local level. You know, like autism, it used to be, I've also just seen autism used to be sort of 1 in 2,500 children, and it's now 1 in 36 apparently, for example. Things like that, which there's definitely something somewhere going on, and it's quite hard to piece together exactly what it is that causes this sort of thing.
Could I just step back in? I think we need to be really cautious about saying that prevalence is increased. I think our diagnostic and awareness has increased. Yeah. We probably underdiagnosed in previous decades, probably.
Sure, just, I mean, again, we're coming on something quite big, but if we're in a situation where 1 in 5 people is having things like this, then we need to look at how it's being dealt with, I think.
Thank you. I have Councillor Berry now.
Just very briefly, clearly government is planning to reduce the diagnoses effectively going forwards, hence raising the bar for assistance and beyond. How do you deal with that with our team? Because clearly they'll be seeing what they see now, and how do they unlearn what they see now to make it somewhat less sensitive than it is currently, if you get me?
So this is why, and we've already implemented it within children at the start of this year, January, we've moved to a needs-led referral process. So it isn't about severity of neurodiversity, it's what's the impact of neurodiversity. So, and we are working really closely with schools and parents. So we will take referrals from anybody, but we really encourage parental referral or school referrals. And if there were GPs in the room, we are discouraging GPs. And the reasons we're discouraging GPs is that they usually see children for 10 minutes. So we want to get to, we want referrals from people who actually know the child. The person who knows the child best is probably the parent or the school. And we like them to work in partnership together. And we like to focus on, so what's the impact, if you think your child's neurodiverse, what's the impact so that we really understand the needs of that child and how we support from a multi-agency and multidisciplinary perspective.
Thank you. Councillor Sam Blackwell.
Thanks. I really agree with this approach about really going into the schools and starting there rather than waiting for concerned parents to come up and try and get these assessments, which are so difficult to go through the whole process. And clearly, yes, there is a much more awareness of this, which I can only see as a good thing, really, because it's about supporting people. But I appreciate how much challenge that puts on the services. So a new approach is definitely needed. Could I just draw your attention to the waiting well provision? Because when I have conversations with parents in this situation, this is one of the biggest sources of anxiety. And I think, Val, we talked before about, some of the staff were TUPE'd across from Avon, Wiltshire, but others weren't. And so, obviously that has put pressure on your new team. But I hear a lot from parents saying, look, I can't even get a phone call back. No one is acknowledging this. Obviously then once they're in the process and then they understand that it's potentially years, well, actually it is years in many cases, but just getting there and knowing that you're on the radar is just so important. And so, it's great that you started this, but could I suggest that this should be one of the areas of focus because it's such a source of anxiety among parents?
Yeah, so, just to come back, so if we just separate the two issues slightly, so the children and young people did not, that service did not come from AWP, that's the adult service. So just to separate, because they're very similar issues, but slightly different issues. So you're absolutely right that, and we are monitoring concerns and feedback, and going back to that we haven't got our single point of access and care coordination centres. That's right. So that's part of the transformation work, and part of that, get our care navigators in place to really help individuals. But also working with our wider colleagues. So we, if we focus on that needs-led approach, we are working really closely, for example, with our Wiltshire Council colleagues, social care, our youth justice system, those young people on the edge of criminality. So those young people, children, we can expedite. So we really understand and get them in front of professional earlier. So we're working together to try and get to the right individuals. But yes, we haven't got our care coordination centre right yet. The adult services is a slightly different services that were transferred to us. The ADHD adult service did not come across with any staff. We have now been recruited. We have a lead psychiatrist in place now supporting that service and a team around them.
Thank you very much. Any more questions from committee members? No, I was going to suggest, I'm always very interested in the work of the pioneers, and it's perhaps something Caroline Finch would be interested in saying something very briefly about. But my understanding is that the pioneers are a network of disabled and older people from across their county, and the purpose of their raison d'etre is to share their views and expertise to help develop and design services so that they can live well. I'd be very interested when you come back in November to hear more about the work Caroline is saying. Yes, and it would be very, very welcoming if a pioneer felt able to come and attend, but I'd be interested in hearing from your point of view what the...
Thank you. I've after the briefing on Friday, I've already emailed Val about the pioneers and put her in touch with Mary to take that forward.
So I will absolutely follow that up, and I will ask our partnership engagement. I think they've had some linkage, but let's do a little bit more.
I think it's through Send, actually. Yeah. And also, I mean, you know, the next meeting, I've already had a message from Mary saying they'd be happy to do like a training session to show what
That would be fantastic. So a pre-briefing session for us.
whatever. Yes.
Yes. I'm quite happy if we have a pre-briefing and we have pioneers here to provide biscuits and coffee. Yeah. As an incentive, that would be good, because I think that's an example of how it really feels for people, and that has to be the focus of this committee is what does it feel like? Diane, please.
Thank you. I know we're particularly talking about children and young people at the moment, but I would also like to say that I'm on this committee because I'm the chair of Wiltshire Service Users Network, and we actually run the only autism hub that there is in Wiltshire. I think you've probably been in contact, but I would just like to say that as we are the only organisation that offers that. Thank you.
And I think I mentioned, for those of you that were on the informal meeting that we had, please, if there's groups that you think it would be helpful for us, please email me anything and I will link our partnership and engagement, who may or may not already know them. Wiltshire have a very, very large number of wonderful community voluntary sector groups, so I think about 2,500, so we will not have got to all of them yet. But if there's ones particularly relevant to us, then please forward them.
Thank you very much. It's been a very interesting discussion, and can I invite you to return in November to talk about both of these areas? And I think the anonymised case study is a really good idea, because, you know, and through the focus of your 4Ds, rather, is the kind of what it's like now, what engagement you've done with service users, and what the transformation will be, and how you'll measure outcomes would be fabulous. And in layman speak, that would be super. And then the other thing, which we haven't actually brought up in conversations, but it's been it's in the report, is the dashboard should be available in September 2025. So is that something that can be circulated, or can it be brought back to us? Is it ready yet? Yes.
So through our internal governance and commissioners, but by November, I think that would be possible.
So if that can come back in November too, that would be brilliant. Thank you very much for your time. That's really interesting and enjoyable. Thank you. Our next agenda item is the update on the implementation of the Dementia Strategy 2023 to 2024. It's on pages 41 to 72. And I note we have Alison Elliott online, and we have Victoria Bailey here. I think Victoria is going to present the information, and Alison is here to support and answer questions as necessary. Thank you. Oh, I should just give some context. The committee last received a presentation on the dementia strategy in September 2024 and requested then a further update on how the strategy has been implemented. So what the changes. Further information from 2 services commissioned by the council and delivered by Alzheimer's Support, the Dementia Advisor and the Dementia Community Services were specifically highlighted. The report for this starts on page 41, and there are also included are 2 annual reports from the Alzheimer's Support on the services that have been provided. Victoria Bailey.
Thank you. Taking the report as read, I've just done a short presentation just to pull out some of the highlights on the report and how the work within the contract links into the dementia strategy. Our dementia strategy started in 2023 and runs until 2028. There is quite an active working group around this strategy, and some of the key focuses over the last year have been around supporting people well. It's a real focus on the Dementia Advisor service and the community service contract that we've been asked to feedback on today. There's been some great work around the roadmap, and there is a link in the presentation to the roadmap, so if you haven't had an opportunity to have a look, I would. And then really establishing that working group. We've done a bit of a review of the strategy and the implementation, and thinking about the making things kind of reportable. We've had quite a lot of actions previously, so working with the working group to reduce that and to make it a bit more manageable. Some of the focuses for the next year, we'll be working with GP surgeries, ensuring that we've got information available. Continuing that cross-working with the dementia strategy, the carer strategy, and then also looking at, we are doing an all-age accommodation strategy, so making sure that as a commissioning team, all of the strategies that we're responsible for linking together. There's also been some work and engagement as well out in the community. The 2 contracts, they are in place until March 26. So as part of our ongoing contract management and work with health, we will be doing a review of those contracts to look at. So within the contract, there is the option to extend for a further 2 years. So that piece of work will be happening over the next couple of months and going through our internal governance around what we would do with that moving forward. But both of those contracts are working really well. So the advisor service is that kind of initial front door. So there's been some focus around the evaluation against the diagnostic rates, and looking at the measures around length of stay. And then with the community service, the focus has really been around increasing that capacity and engagement with the community groups. I think the next slide is just some information around the roadmap. I'll be happy to take any questions.
Thank you very much. I was fascinated to see the work that's kind of done on the grounds by people, because certainly as a councillor living in a community, you know, this is where the rubber hits the road. This is what makes a real difference for people. So it was fascinating to have that explained. Questions that came up in my mind were around differential diagnosis rates. And one of the things that highlighted this for me is where Diane Gooch works in the Cairn area. That is highlighted as an area of kind of especially strong work. And diagnosis rates increase in response to kind of focus, if you like the Marlborough Health and Wellbeing Day was mentioned as creating a spike in dementia diagnoses. And how, looking forward, how integrated are you with the health service in terms of supporting diagnosis? Does it all come through the primary care network? Is it all GPs? Because we've just heard about the neurodiversity pathway that GPs see people for 10 minutes. Can you make any comments around that? And perhaps Diane would like to speak as well.
Yeah, thank you. I had a little bit of prior warning, so that we might get asked this. So I've got a little bit of information for you. So this isn't my area of expertise normally. So if there's anything onwards from this that you need, please do shout. But in terms of dementia diagnosis rates, across BSW, there's a target of 66.7%, but for BSW we average around 61.4, which is the same as the west of the southwest. It's just obviously not meeting the national target. For Wiltshire, we're slightly higher, so we're higher than the regional average at 63.8%. So it's just under the national target for the dementia diagnosis rates, which is positive. There's quite a lot of work happening at the moment around trying to improve the dementia diagnosis rates. You're right, a lot of that comes through our GP practices. So we have something called a locally commissioned service, which is an extra contract with our practices to encourage them to help diagnose dementia. And there's only one practice in Wiltshire that's not signed up to that. So we've got really good coverage of that, which is really positive. And what the team do within the ICB is they look at the performance of different practices and try to provide support and information to them. So particularly those practices where their numbers may be lower as well, to try and encourage that take up and diagnosis. There is also work that we're doing with AWP as well, so to support how they can access GP records to update codes directly as well. So if AWP diagnose dementia, then at the moment the primary care need to put those codes on. So that might not always happen in a timely way. So we know that's an issue. And through the mental health strategy, which obviously is slightly wider than this, there is also a memory assessment work stream. So it's a real focus and a priority, which all providers are involved with, and that will help us to form our intentions for 2026 onwards with colleagues in Wiltshire Council as well and across BSW. So I hope that's a little bit of background.
I think that's very helpful. I'm looking around the room. One thing that Elsa that came to mind is looking at the financing of the two streams of work that Alzheimer's Support are subsidising, both of those work streams. And obviously they are a charity. But my question was like, is this normal for a charity to be subsidising a partly commissioned service? How does this work? Is it typical? Is it sustainable? If through the work that's being done with primary care networks, demand increases, how are we going to manage that? Because obviously these services are invaluable to people.
And we will pick that up as part of that contract review and then that internal governance. I would say it does happen occasionally where some services do have funding streams from various places, but we will take that into consideration as part of that work.
Diane Gooch, and then yeah, no, it's okay. You go, and then we have Chuck.
I just was interested in, do you have figures on the percentage of people that are diagnosed with dementia by the GPs and those that are diagnosed through the memory clinics? And sorry about this, is there a difference insofar as I am still aware that people are still going to GPs and being told, yes, you've got dementia. What? We need to know the type of dementia. Families need to know the type of dementia, etc. That does appear to happen a lot more from the memory clinic than it does to GPs. That's my question at the moment. Thank you.
So just in terms of the split between the diagnosis from GPs and memory clinics, I don't have that data on me today, but I will go back and ask that question. I hadn't heard the feedback about GPs communicating back around diagnoses to people that it's non-specific, but I will follow that up with the team and with yourselves as well, just to see if that's something that others are reporting as well, because we can certainly pick that up with GPs through the LCS arrangement as well, and just some of those standards that we're expecting.
Thank you, and obviously we'll need that information for the minutes because the question has been asked. It's probably standard. I have 3 questions on this side. First of all, Councillor Chuck Berry.
Sorry, yes, thank you, Chair. Looking at the Dementia Advisory Service, which is voluntary, and then looking at the stats, it's pretty stark that the first line, number of referrals, is about the same, with the exception of East. But then after that, it's quite diverse. Why is it so diverse? Which is the better of the 4 services on that basis? And how do we make them less diverse? Because clearly there are some areas where one, north, south, east or west, might be better than the other. And how do we standardise that? Because it is quite different. And I don't understand why it's that different. I mean, particularly when you look at West, with the number of referrals, probably significantly higher than everybody else, and yet everything else below the line, below that first line, is not significantly different. And I just don't see, the numbers don't speak to me, if you get me.
I do. Unfortunately, I can't answer that, but I will take it away and pick it up with the services and come back if that's okay.
Councillor Redrimmer.
Thank you. These sorts of reports always have to have predictions about future spending, etc. And of course, things like this are going to be based on future sort of demographic estimates of what's going to happen and ageing population and those sorts of things. I always want to know to what extent, when we've made those predictions in the past, does anyone analyse whether we've got those predictions correct or whether we haven't? Because these reports, this one, the last one we saw as well, they always have these sorts of predictions in, and it's easy to just kind of take them as gospel because they're in a report. And I just wanted to know sort of generally, I don't know whether any of you here are people to answer that, whether we analyse how correctly we've made those predictions.
Alison's got her hand up.
Alison, are you going to respond to that question? Yes.
Thank you, Chair. So we use a multitude of data sources to make predictions, which includes our JSNA. I think it's quite interesting, isn't it, to think back, what predictions did we make 20 years ago and did we get them right? I'm not sure we do that, actually, but we have got significant evidence in terms of the veracity of those data sources to allow us to predict future demand, and that's why we use those recognised data sources.
Perhaps you could explain a little bit more about the data sources, because I had a question which shows my ignorance, but I wondered, is dementia in the JSNA, the Joint Strategic Needs Assessment? It is, okay.
Yes.
So what are your data sources then?
So we will use the JSNA, we will use national data sources, we'll use data sources from health. So we use a range of data sources to, we use something called Poppy and Pansy. So we use a range of recognised data sources to predict future demand.
Just to come back, if there's any way that we could regularly analyse how accurate that's been in order to be able to see whether we're on the right path in terms of these, otherwise one risks making predictions, doing things on the basis of those predictions, and then not actually realising whether we've got it right or not.
So I can certainly take that up with our Director of Public Health. I can have that conversation with her. There may well be evaluation of previous predictions that I'm not aware of, but I'll take that away and have that conversation with her.
Thank you.
And as a throwaway comment, you soon see it in the budget figures, the outturn reports. Yes, I think Irene Kohler wanted to speak, and then Diane, please.
I've been looking at the stats as well, and I see there's issues about the number of cases closed, and I'd be interested to know how many have closed because people have died, how many have closed, but also how many have closed because they've been attending a day centre or a day service of some sort, and their dementia has progressed, and they've been told they can't come anymore. And where do they go to? Say they might have gone into nursing care, but I think all too often they're left to the family to care for them, and I think that should be addressed.
Thank you. I think that's a really good observation on the data. So we'll pick that up with the contact monitoring and see if we can get some of that information around where people are. I think that's really helpful. Thank you.
Diane Gooch.
Thank you. I'm a bit confused about my understanding, which can be completely wrong, was that when the dementia advisors, they do not keep open cases. So therefore, I'm making a presumption here about the number of cases that were closed. Maybe we could have some better clarification on that, because I don't believe that they are kept open. So I think we should know that. I'm sorry, thank you. And the only other thing I was going to say, and I'm sure that, as you know, this is my passion, working with people with dementia, and I'm sure all of the other councillors have actually been and had dementia awareness sessions. And hopefully if anyone hasn't, they can certainly, well, it can be done through me, or they can be organised through Alzheimer's support. Just wanted to throw that in, because I think the more people know about and understand dementia, and can I just say from the Calne point of view that we became a dementia friendly town a long time ago now, and all of the councillors know that when they actually come on board, they have to have dementia awareness sessions, which is absolutely brilliant. But they're also very, very supportive. All the work we're doing with the school at the moment to raise awareness has been because of the support of both our town council and our area board with their funding. And you can really achieve an awful lot. Thank you.
I think you're absolutely right there, and it was very clear to me reading through the reports how useful and incredibly valuable the work you are doing with the area boards is, and it led me on to thinking that there is going to some of the area board funding that came from adult social care for the older and vulnerable people partner, a little bit of has been kept back because they are setting up a kind of a new system of carers champions, support champions for different areas, and that's something that is very exciting, I think, and I think that's something that we should invite commissioning to come back and speak to. I don't know if Alison just wants to say a few words about it, but it might be the substance of an agenda item in future. What do you think, Alison?
Yeah, so it's in the very early stages in terms of the reinvigorating of the carers champions across the area boards, but certainly we can come and give more details about that at a future meeting. Might be as well to leave it a while so we can do an evaluation of the impact.
Okay, so perhaps in spring, but
yeah.
As a councillor, I'm acutely aware, and through my work with adult social care, it's become very, very clear to me that for the majority of people, at least at the beginning of their support journey, it happens in the community, and councillors are embedded in the community. So the more we can educate, inform and support our councillors to gain knowledge, then the better those will be. And I note in all of the papers the increasing focus on working jointly between the NHS and between council services, for example. So I think that's an area that I would definitely be interested in bringing back. And I'm ashamed to say, Mulberry used to be a dementia-friendly town, and we used to have stickers on all the doors and things like that. People used to be able to go in. That's kind of fallen by the wayside, and of course the shops have changed and this and that, and councillors no longer have dementia awareness, but it's perhaps something we can take to Mel Gibson to perhaps bring back to the area boards. Thank you. Not Mel Gibson, you know who I mean. Oh, I'm daydreaming again. Right, moving swiftly on. Are there any deflecting quickly? Are there any more questions? Because I take note during these meetings about who's winning on the left and right hand side of the table, and the right hand side currently is not doing as well as the left. So, Councillor Chamberlain.
Chair, thank you. It's not a Mel Gibson question. It was more about the contract coming up for the end of March next year. I mean, clearly there's some confidentiality around that, but what are your sort of timelines for that? Because that feels like something, given the time scales we work to, that feels like approaching quite quickly. So what would be your sort of your timescales for knowing whether that was going to be extended or a new provider contracted with?
So it will be within the next couple of months. So there's a couple of different internal governance routes that we need to go through, and it's already I think one's September and one's October. So yeah, by the end of the year to ensure that we've given them kind of 3 months notice around what's going to happen at the end of the contract term.
Thank you. Are there any more questions? Oh yes, hello, Irene again, please.
I'm very aware that Alzheimer's Support have had the contract now for about 8 years, I think, and it was previously they did 2 parts of the county and they took over the whole county. I'd be really interested to know whether the services across the whole county are now equitable, or whether there's still a predominance in the 2 areas that they previously had, when they previously just had the 2 areas. And, or whether it's possible to see a map of where all the services are around the county. Because I've read in this report things that I've never heard of in Salisbury. Okay.
So I think that almost relates back to as well the data question around some of the differentiation we see in terms of some of the figures and the referrals, because there will be obviously local variation and local flavours in terms of the priorities for those areas. So I think, as Vicky said then, I think we can obviously share some more data or information that dives a little bit deeper into some of those areas in terms of what is the reason for the differences that we're seeing in the figures, and then, you know, but if the communities obviously are going to shape what some of those responses look like, then we would expect to see some degree of variation. It's about, are we meeting the needs of those local populations, and our assurance to be able to see that that is happening, even if the numbers do look slightly different as a result. So we can pick that up, can't we? Yeah.
Councillor Chris Williams.
Thank you. It's not a question, but it's an observation. Our area board, Luggishall, had a very successful memory cafe in the Wellington Academy, especially at lunch times, where the pupils and through the cooking side of life would provide meals and that, and there was entertainment put on, and it was a great success for a year or so with funding from the area board. Then it just died and all that because of the data side of life, what the care or the people who are volunteers had to go through, and they weren't willing to go through this data protection and all that, and so it just died a death, which is a great shame, because and I think if you want to get more people involved in this and to run these things in a voluntary nature, I agree there's got to be a certain amount of vetting takes place, but we mustn't make it too difficult for people to get involved in it. There are other things happening in our town anyway, so you have the church breakfast mornings and this, that and the other, and other clubs and all that. But to actually say it is a memory cafe has to have these, yeah, quite rightly, correct checks in place and all that. But we've got to make them easier for people to get involved. Thank you.
Yeah, I mean, just to come back, I mean, I would agree. There are some kind of, requirements that we would have to support around sort of safeguarding, and obviously where there's regulated activity and those sort of safeguarding responsibilities. But I mean, I completely agree with you around the need to make any of those processes as easy as we can, so that those communities can kind of, generate their own ideas and their own support. So, I mean, if there are specifics, then obviously we'd be happy to help and see what we can do to facilitate.
Thank you. Any more questions? Councillor Cape.
Thanks very much. It was just to point out there's a bit of information on the council's own website about numbers around dementia, and also to draw colleagues' attention to the NHS health check that includes it. I'll forward the links.
Thank you. That would be very helpful. Are there any more questions? No. Well, I suggest that we resolve to receive information from the ICB and from our internal staff on dementia diagnosis rates and equity of provision, the data that we've discussed today. Now, is that something that you can provide in time for it to go in as a kind of along with the minutes? Yeah. So prior to the next meeting, so we can see it and agree.
Certainly the dementia diagnosis split, I'll request that today, and if we have it, then certainly it can be put in the minutes. I'm sure it's available.
Yes, we don't sign off the minutes till the next meeting, so it can come in as long as it's here with us by November for consideration. Thank you. And time for people to ask questions if they want. Thank you very much. That was very interesting and helpful. Thank you. It's very good. Our next agenda item is on the future commissioning of community-based services. This is a paper that's going to Cabinet on the 16th of September. Sometimes Cabinet papers just come to the Chair and the Vice Chair, depending on timings, but I thought this was a good opportunity for the whole committee to be able to scrutinise the proposal. The Cabinet report was only published yesterday, so it came out as an agenda supplement. So apologies for the short notice, but it's unavoidable in these circumstances. Councillor Gordon King is going to introduce the paper, and then Emma and Victoria might add supplementary information or answer questions. Thank you.
Thank you very much, Jane. As you know, this came out of a Cabinet approved the commencement of the commissioning process on the 16th of March 2025. This paper in front of you explains the process that resulted from that decision, namely an extensive co-production consultation with Wiltshire carers and what sort of service will result. There seems to have been a universal acceptance that the right care should be delivered in the right place and at the right time. That provides independence through a good approach in care in the home rather than in a hospital or in the care facility, all of which is provided by a market that is both sustainable and can deliver high quality care and support. Given Council's commitment to providing the best, what's best about in life and building a resilient communities, it feels right that that is what is really, beg your pardon, that what is being commissioned will be beneficial for both children as well as adults. Care is currently provided in 3 different frameworks, where the emerging preference is to combine these into a single framework that is better able to deliver against the pressures of demand and get the best out of what the market's terms of service and price. These are significant pressures going forward. Wiltshire is one of the 3 counties in the south to be experiencing significant population growth in the over 65s and the over 85s. There is also significant growth in the home care market, an oversaturation, in fact, which represents risk into smaller local providers should there be pressure to create or mergers within the care market. So throughout the paper, you will be able to see lots of summaries about what that co-production looked like, what the market is based upon, and a clear description of the services that will be delivered. I will leave it to Emma to include anything I might have left out.
I've just pulled out a couple of key points. The work around looking at all of community-based services has been ongoing for probably about 12 to 18 months. So this is quite a large tender that we'll be looking to do. It will also be the first tender going out under the new procurement regulations. So we've been working really closely with procurement and legal colleagues around what that might look like. And working directly with providers, having a number of different contracts and frameworks at the moment is really difficult to manage, both from our perspective and providers' perspective. So that's why we're looking to align into one overarching framework and also linking up adults and children's. We do have some providers that support both adults and children's, so that's going to be much more consistent. We are looking at a number of different service types. So we're looking at home care, supported living, individual service funds, which comes under the self-directed support piece of work, extra care. I have noticed actually I've missed one off there, and living care is something else that we're looking at, and also trusted assessors and reviewers, so engaging much more with our provider market. Having a single framework ensures that we've got consistency around our quality standards and expectations and the contract terms and conditions. And with this framework, there is a much more robust process that providers will have to go through in terms of that evaluation criteria, particularly with home care and where there is regulated activity. We will expect providers to be registered with CQC. Another piece of work that we've looking at is obviously around the cost element and what that looks like, and really streamlining that. At the moment, we have various different rates for different service types. We have also looked at the geographical locations and are expanding that to support providers to build runs in specific areas. Happy to take any questions.
Councillor Chris Williams.
Thank you. How does this tie in with what we were discussing earlier this morning with the HCRG contract and the Integrated Care Board and all that? Because just looking at the words there, there's a lot of similarity between the two.
And there is a huge amount of overlap, and the kind of health and social care system are, kind of codependent, and we rely on each other. What I think we're talking about in this paper is when people have long-term care and support needs and they need care to remain in their own homes. This is the framework that we will use to commission and broker with providers to provide that care in someone's home. So obviously all the things you've heard from the HCRG discussion will be about how we're supporting people with their health needs. This is how we are going to ensure that somebody is able to get up in the morning, get dressed, have their breakfast. So it's that element of how we meet someone's needs from that sort of holistic perspective.
Thank you.
Councillor Tamara Ray.
Thanks. I've got two questions and a comment. The first one actually builds on what Chris was saying. Now, I'm attending this today as a substitutes person. I've been to this meeting. Chris, obviously, you've been a long-standing member of Health.
Well,
Oh, forgive me. I thought you were vice chair in the Environment Select. Sorry, forget that. But what I was just thinking, it'd be really helpful to have the sort of a framework, a diagram of how all of the services fit together. I did go back to the council induction slides, but that was, I think, more about the statutory responsibilities rather than the products and services that the council commissions in order to deliver on those. So that's my comment. The two questions really are firstly relating to, I think you've just touched on it, commissioning breaking down into smaller geographical areas, into 21 areas. That's quite interesting. The balance between economies of scale and quality of service, etc., etc. So I'd be interested in your perspective on that. And then there was another point, the packages in 25 and 24 and 25 are both noted in this paper. And for the adult packages, there's actually a reduction in between 24 and 25, which sort of wasn't logical given the pressures that we know on demand. So those are my two questions.
I think Alice has got her hand up, if that's okay, Chair.
Tamara, can you just put your microphone off? Alison Elliott, please.
Thank you. So if I can take them in reverse order. The reason for the reduction that you have seen in the paper, so whilst we haven't seen an increase necessarily in demand in adult social care, we have seen an increase in the support that is required. So more complexity for individuals, so therefore higher cost. So that's what we're seeing in terms of adult social care. We are seeing a greater increase in the numbers of children and young people coming from children's services into adult social care. But in terms of the number of home care packages that you're seeing in this paper, it's about the complexity of the package and the size of the package rather than the numbers of people. Your second question was around areas, and economies of scale. So we are breaking the county down into 21 areas, because if you think about a home care business, if you want to be able to be economic, if you like, and make a profit, you need to have quite a short run so that people can move from individual homes within a smaller area to provide the most care for individuals. That doesn't mean that the organisation that's providing that care can't bid in several areas, so they could be working across a number of areas. But because we've contained those areas around towns, as we've called it, they can develop those runs that makes it more economical for them. Does that make sense? Yeah? Okay, and your first point was in terms of if we could have some kind of chart that discriminated in terms of the services so we could understand them better. So these services that we're commissioning are social care services. So they are services that enable people to remain in their own homes, as Emma quite rightly said, when they have long-term support needs. They are not health services. The services that are provided by HCRG are health services. So we do absolutely work together because people have both health and social care needs, but we are responsible statutorily for providing these services. So we have a responsibility within the Care Act to make sure that we provide services for people to remain in their own homes. The complexity of that chart we could have a look at, but I think it is a very complex system. But we could see if we could have some kind of simplification around that, but that would be quite challenging, I think.
Councillor Chuck Berry.
Thanks, Alison. Looking at exactly what you said around home care or care at home, there's going to be interspersed self-funders with those we're funding ourselves, and we can't manage that to make it easier for the people we're commissioning, if you get me. So in the perfect world, you'd want to say, well, all my customers are on a street and they're all close together, but they'll be interspersed with those who are self-funding who choose to use something else other than the ones we've commissioned. Is there any way we can help by aiding the companies we commission getting into those who are self-funding in some way, because they may not even know who they are? First thing. Second thing, the worry for us as a council is not the number of people coming in who are expanding our requirement of delivering care, but it's the one number of people coming in who are expanding our requirement of care who can't pay for it. So if we had a load of people coming in who were wealthy, it wouldn't worry us particularly, because that would support self-funding and not incur additional costs to Wiltshire. So is there a gauge as to the importation of care requirements coming into a sector that is financially deprived, or is there something else that's going on that we're not aware of? And then finally, the greater complication, is that because through our very successful reablement programme, we've squashed up those who need care, and they need far more care because they've been reabled until the time when they can't be reabled anymore, if you get me, and they become quite complicated people to deal with because everything we've taught them in the past has now become not possible for them to do, if you get me.
Okay, I'll go in reverse order if that's all right, Chuck. Yes, we do have a very successful reablement service that we have expanded since April this year. This is about the fact that we have a significantly ageing population. So within Wiltshire, we have an ageing population, and sadly, as you age, you are more likely to have multiple conditions. We see that people are, as they live longer, which is great, that's what we should all hope for, but as they age, they will have multiple conditions, okay? So that's why we see the greater the size of the package, the ability to support people at home. They need more care to stay at home, and because people want to stay at home and don't want to go into residential or nursing care, then we have a responsibility to support them to stay at home. So that's why you're seeing the increase in the size of the package, if you like, to keep people at home. In terms of the self-funding market, then yes, we have a significant challenge in Wiltshire because the self-funding market is our biggest competitor, and we don't have any control over that market, you're quite right, but providers do. So most of our providers will have about 50%, I think that's right, Vicky, of their clients who are already self-funding. So they know those clients and they will be part of that run, if you like, that they make up. So from a business point of view, if I'm a provider, I will know that at number 5 and at number 7 and at number 24, there are 3 self-funders. And I know that if I can get council's clients in between those houses, then that will make me more profitable. So they know that already, and we've been talking to them about that, and they want those smaller areas so that they can develop those runs. So that's why we're developing that. In terms of people who need our services, we are the local authority who has a responsibility to support our residents in Wiltshire. And those residents who do or are unable to fund their own care, we have a responsibility to support them. We have a statutory responsibility to support them under the Care Act. We are not seeing the numbers necessarily increase, as I said earlier. We are seeing the demand for the level of care increase. So we're not seeing an influx of people who can't afford to provide their own care. We're not seeing that. That isn't an issue for us.
Thank you. Do I have any more questions? No, I think that was very useful discussion. I will take the points raised today and just give that as our feedback at Cabinet. Thank you very much. Very helpful. Thank you, Alison. Our next agenda item is Cabinet Member Updates. Gordon, as you are sitting at the table already, would you like to update us on anything? What's new and exciting in adult social care, please?
Well, adult social care is starting a number of roadshows around the county this week, where we will be talking to and listening to people who are current or potential users of our services, their carers and their families about their experiences and the improvements they would like to see. There will also be some other services present, represented along with some pieces of equipment for people to see. These dates have already been widely circulated amongst our partners and the public. They are as follows. This Wednesday, the 10th, from 1 to 3 at the Olympiad in Chippenham. Thursday, the 11th, between 12 and 2 at the Wiley Room, 5 Rivers, Salisbury. Tuesday the 16th between 1 and 3 at the Melksham Community Campus, and Thursday the 18th between 10 and 12 at Tidworth Leisure Centre. There will also be an online session on Tuesday the 7th of October from 6 p.m. for people who could not attend in person or whose preference is for online sessions. Okay. So, I'd like to talk a little bit about engagement, and that since your last meeting in July, I have spent a morning with the Prevention and Wellbeing team where I met with service team leader and leaders of the South and West teams, where we discussed the work of the team. I later toured around a number of team projects, talked to people who were present within those projects, and was able to see the progress of the work that was going on. These projects are where people exchange experiences and make judgment about what is effective and receive signposting from team members. All participants were particularly grateful of the experience and the ability to get together, and were full of praise for the teams. I also attended the Unpaid Carers Forum recently and introduced myself as cabinet member. The conversation was robust throughout, and yet I was delighted to hear very good experiences again and learn a great deal of from their thoughts. I will be following, caring is very dear to my heart as well, and I will be following through on some of the outcomes that was experienced within that forum. Lastly, I've been working closely with Jenny Westbrook, who is my portfolio holder for commissioning. This month, Jenny has attended the Provide Forum and the Commissioning Directorate, whose service team meeting. Jenny has been able to talk to providers and staff to ensure that they are cited on the issues facing the market within Wiltshire. This is a piece of crucial work going forwards, and the work with the providers on the initiative, innovative models of care. Thank you.
Thank you very much. That's very helpful. Councillor Claire Cape.
Thank you very much. Good to be here. Three just very short things here that I just wanted to share with colleagues. Firstly, Birmingham University asked us if they could run a Gypsy, Roma, Traveller and Boater event here in Wiltshire in the autumn. And this will be based on the excellent track record of public health and wellbeing within those communities, which colleagues are likely to be familiar with much of that. Much of the event itself will focus on use of digital technology for accessing services, which of course is particularly challenging in those communities, so it's really encouraging to know about that. And of course, we're all delighted as Wiltshire Council to be working with Birmingham University to make this a success. So hopefully, once we've got a firm date in the diary, we'll be able to share that. Secondly, thank you to Fairsaver Buses based in Wiltshire, who are providing free travel today on the 9th of September. That's 999 Day for people that weren't aware. So that's for all staff in emergency services, including the NHS. So that's nice to know about. And then I just wanted to quickly reflect back on the earlier item on dementia. The Chippenham Wellbeing Day, which was held earlier this year, included a memory dome. Some people may be familiar with that. And that offered a way for participants to learn about brain and memory. And I would commend that to colleagues who may be taking forward similar events over the next year So, okay.
Thank you,
Thank
that's
you.
very helpful, very interesting, especially about the memory dome. Emma or any other directors, do you have any updates for us? No, in which case we'll move on to agenda item 10, which is the Forward Work Programme. It's attached for information. The start of the urgent rapid scrutiny is still to be confirmed, but we're hoping this will take place in October because it's obviously an area of great interest to us. One question that's still not quite clear in my mind, and perhaps I can ask officers to have a think about how we could best do this, but we should really be scrutinising the impact of the overspend in the adult social care budget in 24-25. You know, my question would be, is it better done in a task group, or is it something that can be done ongoing? Because obviously everyone is hoping that that budget and spending is now aligned, but we need to make sure from the point of view of this committee that services aren't impacted, quality of care and outcomes.
So we'd be happy to work with the team around how we could shape some of that. I suppose the assurance I would give is that, you know, we are very clear in terms of what our statutory responsibilities are to meet people's needs, and we are continuing to do that. So from our perspective, that remains, you know, forefront in terms of our planning. Obviously, we do need to be very aware of the financial circumstances and ensuring that we are achieving best value, but you know, from my perspective, certainly in my statutory role as a Director of Adult Social Services, I need to be assured that people are not experiencing any detriment as a result of that. So I would just give that assurance to the committee.
Thank you. I think it's important that we do get that assurance formally in this meeting, and I look forward to hearing from you about how you think it's best to scrutinise that as an ongoing item. Thank you. Urgent items. There are no urgent items given to me, but I think at the last meeting I introduced a book recommendation, and I have another book I'd like to share with you, and it's called Every Kind of People: A Journey into the Heart of Care Work. It's by Catherine Falk, and it's what it does really brilliantly is it gives real life kind of case study, if you like, experience of people who are elderly, infirm, probably irritable, have other issues, but it shows you how lively and extraordinary human beings are, even when they are in need of care services. And so it's a fun read. Again, it's not too heavy, and that's my book recommendation this month, this meeting. Every Kind of People: A Journey into the Heart of Care Work by Catherine Falk. It was a Radio 4 Book of the Week, which is how I first heard it. It was absolutely brilliant. And I'm looking for book recommendations from other members for the next meeting, please. They have to be kind of health and care related. Thank you very much. The date of the next meeting is 12th of November. Thank you very much, everyone, for your contributions. And I should also apologise to Councillor Mel Jacobs for inadvertently muddling her name. Sorry. Thank you.